All right, so this is the second of our lectures on the knee, and in this lecture we're going to be talking about the clinical pearls and the neurovascular structures in the region. First, the clinical pearls. So this is a table in your book outlining 3 common types of arthritis that can affect the knee joint. We'll go through each of these individually in the subsequent slides. So first, osteoarthritis, definitely the most common. This is, again, we've talked about the arthritis several times, osteoarthritis, wear and tear of the joint space resulting in loss of articular cartilage. So, you have a joint like this, you have cartilage like this. Over time, either you have a trauma, so you have like a fracture through here, or it's just over time and it wears and wears and wears, and then it goes to where it's just bone on bone banging on each other. Okay? Develops after trauma to the knee joint especially, but also is just very common with age, as in the older population. Presentation, it's usually elderly, history of trauma, pain when weight bearing especially, so when anytime people are putting weight on their knees. Pain and stiffness that gets worse later in the day. Remember, that's a big distinction with rheumatoid arthritis, which is actually worse and then gets better during the day. Joint line tenderness, so if you palpate along here on the knee joint, you'll feel that it'll be tender. You could even see effusion, knee deformity if the arthritis is really bad and has gotten to the point where the bone on bone interaction and the weight bearing has caused actual physical destruction or damage to the knee itself. So you could see even knee deformity. And then, this effusion and tenderness is really, when you have 2 bones banging against each other like this, it's going to be a lot of inflammation, and that will cause this tenderness, effusion, those types of things. So diagnosis, x-ray, you can see we have an x-ray right here. On this side of the knee, there's a lot of arthritis. This side actually looks pretty good. It's not too bad. It looks fairly healthy. The 4 big things you want to look for is first the narrow joint space. So if you look, here's the space on the healthy side. See how it's nice and big, nice big space here. This would be cartilage in here. Remember, cartilage doesn't really show up on an x-ray. So this would be cartilage in here. Versus here, it's barely even there. So a lot of this cartilage is gone. There's barely any space there. So subchondral sclerosis, this occurs when, you have the cartilage is worn away, the bones are banging up against each other. You have new bone formation beneath the cartilage or where it was. So you have sub, beneath, and then chondral means cartilage. And that's what gives you this increased density here. As you can see this, whitish areas here and here. This increased density and hardening beneath the surface of the bone right here. So osteophytes is where you have new bone spurs that actually occur. So with this new bone formation, you can have actual osteophytes occurring. You can even see kind of one right there, maybe one right there. Instead of a smooth bony surface, now it's a bumpy bony surface banging up against each other, which further increases the inflammation, further increases the damage, and then again, further increases pain and disability. And then last, subchondral cysts are these bony cysts that begin to form along with subchondral sclerosis, and you can see, and they're actually kind of lucencies like this on x-ray, and so you see these also begin to form in an arthritic knee or any arthritic joints. So really you want to look for these 4 things. Again, to review, your narrow joint space, your subchondral sclerosis, subchondral cysts like this, and then your osteophytes, which are these bumps like this. Treatment, there's a lot of information in here, so you're going to give NSAIDs to calm it down. If those don't work, you can actually put a steroid injection here, very common office procedure to give someone a knee injection, put a cortisone shot in there. And then if it gets to a point where those don't work, patient has significant disability and they're old enough, typically you don't do a joint replacement in someone who's under 50, is if they're old enough, then you can do a total knee arthroplasty, which is where you actually go in and give them a new knee. Rheumatoid arthritis, so again, we've talked about this in a few of the other musculoskeletal lectures, but again, it's an autoimmune disease, and then it results in the immune system attacking the joints. It's seen usually in younger patients, so 20s, 30s, not 65, which is where you see osteoarthritis, so that's one big difference between the two. For purposes of the board exam, if you see arthritis in a younger patient, it's usually not going to be osteoarthritis unless they had some significant trauma in their childhood to their one of their joints. Presentation, pain and stiffness that's worse in the morning. It affects the joints bilaterally. This is another important thing to be aware of for board exam. It's usually, it's a systemic disease, so it's going to affect all the joints. And so it'll affect both sides. Versus osteo, it may be, maybe the right has a lot of arthritis and the left has little or no arthritis. So, the osteoarthritis are not on the same timetable versus rheumatoid, where the joints tend to be affected the same on both sides. You'll see effusion, which again is that inflammation, decreased range of motion, which is an important thing to note here for rheumatoid. You also see nodules and deformities. So you'll see bony nodules, the bones bang up against each other. You can see deformity also of the joints resulting from this immune attack. Diagnosis, so you're going to do an x-ray and you're going to just see massive joint destruction from the immune system attacking this. Labs, you'll get a rheumatoid factor, an ANA, you'll get inflammatory markers, ESR, then you'll get CBC just to look for your white count. Treatment is immunotherapies. Methotrexate tends to work well for these patients. And then if it gets really bad, you can do a total knee arthroplasty. And this is actually a case where you may do a total knee arthroplasty in a patient younger than 50 if it's gotten to a point where it's so bad. So gouty arthritis. Now, gout in the real world, gout is actually more common in the feet and the toes, not so much in the knee. You can definitely see it in the knee, but it's not as common. But the reason we bring this up here is because it's actually a fairly common board question to ask about gout arthritis. So you definitely want to be aware of this. You definitely want to have this on your differential when you're looking at a board question with knee pain, especially if it's more an acute episode. So it develops when there's a high serum level of uric acid, as we've talked about when we talked about gout in other areas. Forms crystals in the knee that result in inflammatory response. So you have this high uric acid, so UA, crystals form, which causes, these crystals will form in the knee here. That results in inflammation. And then that results in pain. Okay? And this happens a lot faster than osteo or rheumatoid arthritis. And so it presents as an acute episode. And it's pain, especially when they're putting weight on it. These people are going to be in really significant pain. They're going to have swelling, red and warm skin, so real inflammatory signs. And so the way these will be diagnosed is they'll do an x-ray. They'll have normal joint space because their cartilage is still intact. They may have some punched out lesions, like this within the knee, may have some soft tissue swelling, but x-ray is not going to be your main diagnostic tool here. Labs, you'll get a CBC, some inflammatory markers, may see an elevated white count because, there's a lot of inflammation going on. But the big thing here with gout is you're going to do a joint aspiration. Now, just because they did a joint aspiration doesn't mean it was gout. You can do joint aspiration for osteoarthritis as well, rheumatoid arthritis as well, or other, especially in septic knee, which we'll talk about here in a couple slides. Just want you to be aware of that joint aspiration just doesn't mean that it's gout, but it is the main way you diagnose gouty arthritis. So what you're going to see is a high cell count and the presence of negative bifurengence crystals. Now, sometimes they'll show you a sample of the aspirate from the knee and they'll show you these crystals. Sometimes they'll just tell you that they had these crystals. So you definitely want to be aware of that. This would be versus pseudo-gout, which is another common board question, which can affect really any joint, but you can see it in the knee. That would be where it's actually positive bifurengence crystals, okay? Very similar presentation, acute pain in the knee, normal joint space on x-ray, but then the difference is you tap the knee and then you see positively bifurengence crystals versus negatively bifurengence crystals in regular gout. Treatment here for gout is you give NSAIDs and you give colchicine. You do not give allopurinol, which is the long-term treatment for someone with gout. In an acute setting, you're going to give NSAIDs. Colchicine would often give because the patient can't tolerate NSAIDs for some reason. Maybe they have a history of stomach ulcers. Patients are more at risk for stomach ulcers by NSAIDs. But this is always the first step in managing these acute gout flare-ups is you give NSAIDs or colchicine. Then you also rest it and provide ice. So ACL tear, the big way to differentiate an ACL tear versus a PCL tear is the description of how they actually injured themselves, so the history. So ACL tear is going to be very typical for pivoting injuries, twisting of the knee. So often like a soccer player pivoted and ran around somebody, or a basketball player was pivoting, or someone jumped and they had an awkward landing and knee hyperextension, because remember the ACL prevents hyperextension. So it's going to be something like this in the history. On presentation, they're going to have knee pain, obviously, immediate swelling, and then knee instability. So that's another thing is they'll say, after the injury, the patient felt like when they were walking, their knee was going to give out. That's a big buzzword or buzz phrase for ACL injury. And then hemarthrosis, which is heme meaning blood, arthrosis joint, so blood in the joint space. Physical exam, you can do that anterior drawer test I was talking about. You can do a Lockman test or a pivot shift test. Sometimes they'll mention these in exam question stems. Diagnosis, an MRI will confirm it. So you have your clinical suspicion and then you get an MRI and confirm it. Treatment, you got to do surgery. So arthroscopic surgery. Arthro, again, joint, scopic. So it's with a scope. So you stick a scope into the knee joint, fix the injury. PCL tear. So history is they fell onto a flexed knee. So if you remember, PCL prevents hyperflexion. So if it's usually someone jumped up for, basketball player jumped up to block a shot and they come down and their knee was flexed and they came down on that flexed knee, that could tear the PCL. Or a bent knee hitting the dashboard during a car accident. So if you remember, this prevents posterior dislocation. So the knee hits the dashboard and it pushes the tibia backwards or posteriorly, tears the PCL. That's another way to injure it. Presentation, you're going to have knee pain more in the posterior region, swelling, and then knee instability as well. Physical exam, you're going to have a positive posterior drawer test like we talked about. MRI will confirm the injury. Treatment, you immobilize the person in an extension, and then you can do physical therapy. And if it's really bad, you could do arthroscopic surgery for this as well. Not as common to do surgery for this as PCL. Usually you try to do this instead, but if it is really bad or these aren't working, then you switch to surgery. So an MCL tear, so here's your MCL right here, and then here's your tibial collateral ligament, another name for the MCL there, on your posterior view, anterior view. Direct blow to the lateral aspect of the knee, so this side right here pushes the knee in this way. That can cause an injury to the MCL actually, so it's hitting from the opposite side. The LCL is the opposite way. If you hit on the medial side or the inner surface of the knee, that'll affect the lateral collateral ligament. Presentation, they're going to have knee pain on the medial aspect and then difficulty ambulating. Physical exam, they're going to have pain and or instability on that valgus stress. So you remember the MCL prevents valgus stress, so out this way, out laterally. Here's medially. So valgus, remember L, lateral, and it goes out this way. So if you press out this way and you push the tibia out this way and there's pain or if there's some instability as you can go further than normal, that can tip you off to an MCL injury. You have that on an exam, you get an MRI that can confirm the injury. Treatment, you give NSAIDs, you have them rested, you give them a brace, have them do some physical therapy. This is initially a conservative treatment regimen here. And then if it's really bad or if these don't work, then you can do arthroscopic surgery. LCL tear, so direct blow to the medial aspect or the inner surface of the knee. So here's your posterior view here. Here's your lateral or fibular collateral ligament right here. So if you blow from this side, pushes the knee out this way, that can damage the ligament. Presentation is going to be lateral knee pain, so knee pain over this aspect, knee instability, and then difficulty ascending or descending stairs. So this is unique to the LCL injury. Okay, so definitely want to be aware of that. Physical exam, pain or instability on varus stress. So varus, remember valgus is going to be out this way like this. That's your MCL. Varus is out this way or in towards the inner surface here. So this is medial. So that's varus, which is your LCL. Okay. And so you maneuver the tibia inward or medially, provide some varus stress. If there's pain in this region right here, this is a way you reproduce the pain here. And then if there's also instability on varus stress, then that can be suggestive of an LCL tear. You do an MRI that confirms it. Same thing here. You either physical therapy or do surgery. Meniscus tear, another very common injury. This is also involved with twisting, especially with the foot planted. So someone has their foot planted or pivoting and then they twist. That's again, it's in the history. Presentation, it's going to be pain localized to the side of the affected meniscus. So if it's the medial meniscus affected, the pain's going to be on the medial aspect of the knee. Same thing, lateral meniscus is going to be on the outside or lateral aspect of the knee. You're going to have locking and clicking of the knee while walking. And so this is a big kind of buzz phrase for meniscus tear. So if you see this, you definitely want to be thinking about a meniscus tear. Because, if someone comes in with this injury, you could be thinking, oh, it's a meniscus tear, it's an ACL injury. As you'll see in a few slides, you can actually have both. But this is where it's the whole picture. It's the history, the presentation, the exam, everything. And so this is on your presentation. This will tip you off to a meniscus tear. And then delayed or intermittent swelling. So this is another big difference between ACL. ACL, it's going to be right away going to be a lot of swelling. And so versus a meniscus tear, it's going to be not so right away. It's going to be delayed. It might kind of come and go. So that's another big difference with ACL versus ACL is going to be immediate swelling. Physical exam, again, you're going to have some joint line tenderness, so right near whatever aspect is injured. And then this is where it's a difference. You do the McMurray test or Thessaly test. Those will be positive versus an anterior drawer or Lockman test. Diagnosis and MRI will show you a torn meniscus. Treatment, you do rest, NSAIDs, and physical therapy for degenerative tears. So degenerative tears are tears that happen over time. So typically in older people, they're wearing. Same thing as kind of like arthritis, same kind of concept. It's just wear and tear on the meniscus over time. They develop a tear as a result of that. Then you do a more conservative therapy. If it was more, like a young athlete injures it, then that's going to be more prone to having to do surgery. So the terrible triad. So we've been talking about this MCL and medial meniscus connection. So if you remember that, as you can see here, here's the medial meniscus here. So here's that meniscus, and then here's the tibial collateral ligament, also known as the MCL, and they're tightly adhered to each other. They're attached. And so if this ligament gets injured, it pulls on the medial meniscus here, which again is that C shape like this, and it's going to cause a tear or damage to that medial meniscus. And so the terrible triad, and you'll see this on anatomy exams, board exams. So it's a big injury to the knee. Oftentimes it's caused by lateral blows to the knee like this. Also often, since it's an ACL injury, it'll often be, someone's pivoting or changing directions quickly, and then they get a lateral blow to the knee. And so, say a running back in football is running, and then they change directions, and then they get tackled from the lateral side on the knee. They get a blow to the lateral side of the knee. That could be a cause of a terrible triad. So they'll have an ACL tear, an MCL tear, and then as a result of that MCL tear, it'll damage and tear the medial meniscus. So patella dislocation, so again, history here, twisting injury with foot planted or direct impact onto the patella. Presentation is going to be pain on the inside of the kneecap. This is a buzz phrase. It'll feel like they have pain on the inside here, almost where the bone's rubbing up against the femur. Physical exam, they're going to have patellar apprehension and then tenderness over the medial patellofemoral ligament. And so that'll be on the inner side, and they'll have tenderness over that ligament. Treatment is going to be physical therapy and or surgery. So patellofemoral syndrome, this is often seen on the board exam. History, it's going to be anterior knee pain with running, ascending, or descending stairs. Those are key tip-offs to patellofemoral syndrome, or with prolonged sitting. Typical patient's going to be a young female athlete, so a high school athlete, college athlete. Presentation, it's going to be pain in the patellofemoral joint, so this region right here, patellofemoral joint. Physical exam is going to be the patella compression test, and you can see them either mention this or describe this on a physical exam in a question stem, so you definitely want to be aware of this. If this reproduces the pain, that tips you off to patellofemoral syndrome. Treatment, activity modification, so maybe they can't play sports for a significant amount of time to help them heal this. You give them NSAIDs, and then you give physical therapy. Septic knee, this is a very important thing to be aware of if you're, when you're working in the hospital, but also definitely on a board exam. You'll see this on shelf exams as well. It's a intra-articular infection, so similar to septic hip, that results in significant joint inflammation. Most common pathogens, very common board question, is Staph aureus. If it's a young sexually active person, so someone who's in their 20s, college student, Neisseria gonorrhea will be your most common pathogen. Presentation, they're going to be ill, so they'll have fever, acute onset knee pain as a result of the infection, inability to bear weight, that's a big thing. They can't put any weight on it. Physical exam, they're going to have severe pain with passive range of motion, so where they let you do all the work as the examiner, and you move the knee, and that causes significant pain. That's a huge tip-off to septic knee. They're also going to have signs of inflammation, so swollen knee, erythema, increased skin temperature. So diagnosis, you're going to get an x-ray, ultrasound, you're going to get some labs. You'll see an elevated white blood cell count, elevated inflammatory markers, ESR, CRP. The big thing you'll confirm this with, though, is a knee aspiration. There's a mistake in your book. It says hip aspiration. I apologize about that, so make sure you cross that out and make sure it says knee aspiration. You're going to send the aspirate for gram stain, culture, white blood cell count within the synovial fluid, and then crystal analysis. Well, looking for gout, because gout can also, present with severe acute onset pain in the knee, swelling in the knee. So you definitely want to differentiate those two, so you'll get crystal analysis as well to tell if it's gout versus a septic knee. Treatment, if it is a septic knee, you're going to do antibiotics, and then you'll do and/or a surgical irrigation and debridement, or IND. Tumors, so really just an important fact to know here is that the distal femur at the knee joint is the most common site of an osteosarcoma tumor, which is right around in here. These are common in children or adolescents. So, having a tumor in here, that definitely could be a board question or anatomy exam question. So that's a nice fact you want to keep in the back of your mind. All right, so briefly, we'll just talk about the muscles that act on the knee joint. So movements of the knee, there's the two main ones you really want to worry about is just extension, flexion, just obvious. Extension, quadriceps muscles, not much beyond that. Remember, a femoral nerve injury will cause, if you knock out the femoral nerve, you'll lose knee extension because you lose all innervation in the quadriceps. Flexion, your hamstring muscles, if you remember. So these muscles here on the posterior aspect. Sartorius, the strap muscle along here. Popliteus muscles, those all act on flexing the knee. So the pes anserinus, we talked about this in the thigh region. We were talking about the muscles. It's a conjoined tendon of 3 thigh muscles that insert onto the anterior medial surface of the proximal tibia. So this is a posterior view. So here's your tibia down here, fibula down here. So here's where it's inserting right here on the anterior medial surface of the proximal tibia here. And it contains 3 muscles. This is an important fact to know, especially for anatomy exams, potentially a board exam. So it's sartorius. So sartorius coming in here, that strap muscle that goes from lateral to medial. You have gracilis, which travels in here. And then it's semitendinosus, which is this guy right here traveling in. So they all come down like this. Sartorius comes in like this, and then they form this conjoined tendon that attaches down here under the proximal tibia. It travels superficial to the distal part of the MCL. So that's another spatial relationship to be aware of. So pes anserine bursitis, you could definitely see this on a board exam. So its causes are overuse or injury to the muscles of the pes anserinus, and it results in inflammation of the bursa. So, you have your gracilis here, sartorius here. Here's the tendon coming in like this tendon coming in like this, semitendinosus coming in like this. So you have a bursa right here, and this can get inflamed, that protects it from rubbing up against the proximal tibia here. So that bursa can get inflamed due to overuse or injury to the muscles. And so that can result in chronic knee pain or even weakness. So the way these people are going to present is pain, swelling, and or tenderness over the medial knee, and specifically the proximal tibia. So that's going to be your tip-off to pes anserine bursitis. So it's going to be proximal tibia, medial knee, overuse injury. And then the way you treat it is, rest, ice it. There's going to be inflammation, so you give NSAIDs. If it's really bad, you can put a corticosteroid injection in there, and then also have them do some physical therapy. All right, so now that we've finished up the clinical pearls, we're going to talk about some of the neurovascular structures in the region. So first, the popliteal artery. This is the main artery traveling in the region. It's a continuation of the femoral artery after it passes through the adductor hiatus. So again, here's your ACIS, pubic symphysis here, inguinal ligament, external iliac becomes femoral. The femoral splits into profunda femoris, and then superficial femoral, which comes down here. Superficial femoral comes out here. It exits through that hiatus in the adductor magnus muscle, exits through that hiatus, and then it becomes, in this region, the popliteal artery. So the popliteal artery, it travels through the popliteal fossa. So you can see that here. Here's the popliteal artery traveling here. This is a posterior view. Here's your biceps femoris. Here's your pes anserinus tendons right here. So the popliteal artery is traveling here, and it travels through the popliteal fossa, and then it bifurcates at the lower border of the popliteus muscle. So here's the popliteus muscle right here. And then as you can see, just below the muscle here, it splits into the anterior and posterior tibial arteries, which then go on to supply the different compartments of the leg. Some spatial relationships to be aware of. Again, this is a posterior view. So for the popliteal artery, anterior to the popliteal artery is the popliteal surface of the femur, the knee joint, and the popliteus muscle. So you can see that here. Here's the popliteus muscle, knee joints in here, and then the femur would be in this region right here. Posteriorly would be the popliteal vein, which is not shown here, but it would be traveling with it, and the tibial nerve, which is shown here. And then laterally would be the biceps femoris. So this would be lateral. This would be medial over here, because here's that pes anserinus tendons right here, semitendinosus, one of the muscles of the pes anserinus. So here's that biceps femoris, and then the lateral condyle of the femur would be about here, so superiorly. And then plantaris muscle and the lateral head of the gastrocnemius muscle inferiorly. So here's the gastrocnemius. It's actually cut, but here's the origin right here of gastroc, both here and here, flanking the artery. Medially, you have the semimembranosus muscle and the medial condyle of the femur superiorly. Here's semimembranosus right here. So this is the muscle right here, as you can see. So that's superior to it on the medial aspect, and then you have the medial femoral condyle right here. And then you also have the tibial nerve, popliteal vein, and then the medial head of the gastrocnemius inferiorly. So you have this medial head right here. So that's the medial head of gastrocnemius. The gastrocnemius is this large muscle in the posterior compartment of your leg. It's one of your calf muscles. Here's the lateral head here. So medial head of G, and then lateral head of G. So this is one the lateral head of gastrocnemius, and so these heads kind of come together and converge like this, and then form this large muscle that goes down the posterior aspect. So the artery really goes through the two different heads. The lateral head is just to the is lateral to it. The medial head is medial to it, and it goes right through this pocket of the muscle heads. It gives rise to 5 genicular arteries that form the periarticular genicular anastomosis around the knee, and that's shown in this picture right here. Knowing the individual names of these arteries is not typically too high yield for either anatomy, and definitely not for a board exam. It's just good to know what the genicular anastomosis network is. So all these arteries, they come off in some way off the popliteal artery, and then what they do is they connect to the distal portion of the artery, and then the branches are like anterior tibial, posterior tibial, and they're really the purpose, like any other anastomosis network, is to ensure adequate blood supply to the leg when the popliteal artery is occluded or kinked, such as during full knee flexion. So if you really flex your knee fully, you'll kink the artery, and that could occlude it somewhat. So this ensures adequate blood flow to the lower extremity. So a good clinical tie-in here is a popliteal aneurysm. So the aneurysm, just like in the aorta, anywhere else, it's a ballooning or a bulging of the artery. So it's an abnormal dilation of the popliteal artery that often presents with swelling and pain in the popliteal fossa, so in the posterior aspect of the knee. It's a palpable pulsation. So if you have a bulging aneurysm like this, you're going to be able to feel this, and even if you put your stethoscope over the popliteal fossa or the posterior aspect of the knee, you actually can hear bruits, and so it's shots of blood coming through here, and you'll actually hear this on your stethoscope. So you can see that on auscultation over the posterior knee. So since the sciatic nerve is traveling up in this region, and then it becomes the tibial nerve as it bifurcates, you can have referred pain due to compression. So if you have a bulge and it presses on these nerves, the nerve can be felt in the medial calf, in the ankle, or even the foot. So you can have that electric shock pain referred down as a result of this popliteal aneurysm. So that's another important presentation to be aware of. The other thing is distal femoral fractures and posterior knee dislocations. They can damage or even lacerate the popliteal artery due to the proximity to the posterior bony surfaces of the knee. So you have your popliteal is down in here, in this part, you have a distal femoral fracture. If it displaces posteriorly, it can lacerate or damage the popliteal artery. The other thing here is if you have a posterior knee dislocation, so if the tibia were to blast out posteriorly, at us, out of the screen, it would affect the popliteal artery right here. So you could also have it affect in those injuries as well. The sciatic nerve, it travels in the popliteal fossa as well, as you can see here, from the thigh, and then it divides into the tibial nerve and then the common peroneal nerve. That wraps up our discussion of the clinical pearls and the neurovascular structures relevant to the knee, and it wraps up our entire discussion of the knee as well. Now we'll move into the leg.